Okay, everybody, we're going to get started, and to all of the web-based people as well, hello, good morning. So it gives me enormous pleasure to invite you again and to welcome you to the 14th Annual Flanders Family Visiting Professorship in Medical Simulation. And it's hard to believe that we're already at 14 years. We opened the center in 2006. And I think it's been quite successful, and it's been we've had a huge uptake and buy-in from the faculty and all of the hospitals and the university as a whole. One of the things that we've noticed, or at least that I've noticed and other people have noticed, is that all of the great things that we do at the Simulation Center haven't yet transported into the hospital center. And one of the ways that we're trying to understand is how can we take what we've learned and what we do at the Simulation Center and integrate it into our daily clinical practice so that education and simulation become one with what we do every day. And it really gives me distinct pleasure to have not one, but two visiting professors today. So we have Vinay Nadkarni from the Children's Hospital of Philadelphia. And I'll leave you the time to look at Vinay's CV, which is extensive. But just to tell you that he's an intensivist, works in the cardiac critical care area. He has been the author of over 400 peer-reviewed publications, many of which are in the top-tier journals such as the New England Journal of Medicine, both on simulation and on resuscitation. So it gives me great pleasure to have him here today. As well, joining him is his wife, Ellen Deutsch. Ellen is a otolaryngologist. She also is a simulation expert in her own right and heads a statewide association and review of harmful events and is head of patient safety in that area. So I could go on and on with a lot of their background. I think it's best that they do the talking and we do the listening and we ask some questions. So I would first ask you to give us a round of applause for both Vinay and Ellen that are visiting Montreal on the start of what I think is winter right now. So this is going to be a tag team. So Ellen will start and then followed by Vinay. Ellen?
Thank you. Thank you. It's a great honor to be here, and I really appreciate the invitation. My disclosures are only my employment, multiple employers, and the things I'm going to talk about today are actually things that in my conversations or in the conversations I heard yesterday, I think a lot of these ideas have permeated what you do already. You may or may not have the terminology that I'm going to talk about, but I think the concepts, I'm hoping they'll resonate with you because I'm hearing them expressed in conversations. So first I want to start off with the one of the approaches to patient safety, which is whether humans are the problem or the weak link in our efforts to provide safe health care. And we hear a lot of things criticizing humans. We've heard to err as human many times, and even to err as human, don't forget. And that, by the way, is from Dr. Crosscarry, who is a Canadian. Healthcare delivery is a human-modified system. So we've taken a natural system and tried to manage it as humans. Because humans are in charge of healthcare delivery, the search for human in the path of failure is bound to succeed. And if we don't find a human to blame at the sharp end, we will certainly find one of them somewhere along the path. So the assumption that humans have failed always vindicates itself. And so the beatings will continue. But I actually think both the science of resilience engineering and the science of human factors bring out the point that humans are actually the asset and the strong point and the foundation of the system. Humans solve problems, they invent, they create, they improve. And this is a quote from when John Glenn was the first American to orbit the Earth. And even though he had state-of-the-art technology for his time, there were still some things that malfunctioned, and he had to do manual overrides for some things. And so in the debriefing, one of the aeronautical engineers said, "Where else can you get a nonlinear computer weighing only 160 pounds that can have a billion binary decision elements and it can be mass-produced by unskilled labor. So there are a lot of people who agree that humans are really an asset. Lucian Leap says it's not bad people, it's bad systems. Terry Fairbanks, I love his tagline, to better is human. And then some of the human factors engineers say things like to blame is human, but to fix is to engineer. So humans are a great resource, and they're working in very difficult conditions. And in order to improve the healthcare that we give, I think we have to pay attention to the systems that we work within. This is a real photograph from a real restaurant where I went to eat one day, and I think the employees here probably are well-educated and motivated and want to do their best, but there is a reason why I think that they are not washing their hands correctly. Anybody have a guess about why they're not? There's even a sign up encouraging them, wash your hands. Why aren't they washing? Thank you. No soap. So the systems we work in are a critical part of what we're able to accomplish. This is a classic diagram from Pascal Carrion and others about socio-technical systems. We work in socio-technical systems which integrate and have relationships between tools like technology, the organization, the tasks we have to do, the internal environment, the external environment, all these factors that impact what we're able to do and how well we can do it. And the systems we work in are called complex adaptive systems, and that means that they're never completely knowable. So an individual component of the system might be understandable or knowable, but when you put all the pieces together, no single human is able to understand all the interrelationships that occur. So we in this complex adaptive system are agents, and we are constantly acting and reacting to each other. And complexity is a feature of the system as a whole, even though we can understand parts of the system. And the system is constantly evolving, it's fluid, it has dynamic changes. And you know that when you get up in the morning, when you show up with your OR schedule for the day or your clinic schedule for the day, you know that things are going to change. So you start off with a plan, but you know you're going to have to change it. So we continually adjust how we work. Our work conditions are either incompletely understood or underspecified. We have resource constraints, and we have changing environmental conditions. And we have boundaries and pressures and goals that compete with each other. And there are certain things that have to be done to prevent economic failure. There are certain things that have to be done to prevent work overload. And then there are counter pressures from all our efforts to enhance safety or quality or value or equity, whatever our goals are. These sometimes compete with the other constraints and the other goals that we have to fulfill. And there's a boundary of what's safe and what's not safe, but it's not obvious sometimes until you've crossed it. And there's a margin where we sometimes drift into doing things that tend to be less safe, not always clear when we've crossed that line either. Or to put this more simply, this is a quote from one of my favorite philosophers who says, "There's rules to riding a horse, but the horse won't necessarily know them." So in trying to understand and improve the work we do, there's a concept from Holnagel, and I've had the privilege of many discussions with Eric Holnagel and Bob Weers before he died, and Shauna Perry and Mary Pattison. A lot of people have helped inform my thinking. But one of the concepts that's come out is work as imagined versus work as done. We want to understand how work is done. Simulation is a tool for that. But we start off with a construct of work as imagined. Work as imagined is the conceptual view. It's the high-level view. It's the planning view. It's important. It's not, but it's not the same as work as done. And it's not to say that it doesn't have value, but it can never completely capture work as actually done. You've heard the expression at the sharp end or at the coal face. There's work as claimed. This may be a bigger thing in the U.S. than it is in Canada. But it is a skewed subsection of work that gets done. There's work as documented. You've heard, if it isn't documented, it wasn't done. That's not completely true, but work as documented is a source of information for a lot of analyses that go on, trigger tools, audits, all kinds of things. There is work as abstracted, very powerful. Big data aggregates lots of information in a way that will let people see patterns that may not have been evident on an anecdotal or a small-scale basis. Because of the numbers, this information can be very reliable. It doesn't necessarily mean it's accurate. And it has, all these things have a value. There's work as observed. Some of this is Hawthorne effect. Some of this is that if you have an external observer, an anthropologist, a sociologist, a human factors expert, watch what you do, they may come up with constructs of your work that's a little different from how you understood your work. They may see things, workarounds that you've taken for granted, they may be able to articulate. And then there's work as simulated, and that's, I think, very, very powerful way to represent work and may come the closest to representing work as actually done. Again, all of these things have some validity. You just have to understand their limitations and their capabilities. So in situ simulation is a way to look at how we do work, and particularly if you use real teams, real equipment in real patient care settings. Let's see if that'll play. There we go. It's hard to hear, but there's an announcement overhead that there's a fire, and so they're going to have to evacuate the patient. And we did this several times. It's one thing to know that, when there's a fire drill, you have to evacuate. If you have to evacuate horizontally. But once you walk out of the door of the OR, do you turn right or do you turn left? And how do the people who respond know where to come? Because if the people in the OR call the front desk to call the fire department will respond to the front desk because that's where the call originated. So all these systems things you can learn by doing in situ simulations. We can identify latent hazards and system issues, and we can enhance our adaptive capacity, our ability to have potential solutions to this unanticipated threat to our patient. This was an example where we repeated simulations about how to manage postpartum hemorrhage, and the first simulation, the nurses had to go to a variety of different places to get the resources they needed. They knew that took a lot of time. They put together a cart. They started putting things in the cart, everything you need in an emergency. But then over the course of a series of simulations, they started taking things out of the cart so that they could refine what do you really need in the cart. But this could only be done in situ when you know how long it takes to run to this place to get that piece of equipment. So if we think about getting information to prevent patient harm, we have a circumstance where we may have a latent safety threat or a hazard. Sometimes that hazard may escape and be a near miss where you almost harm a patient. Sometimes whatever that event is may actually reach a patient. You can have something that you didn't want to have happen to a patient, but the patient isn't actually harmed. Maybe they fall, but they're not harmed. They could have minor harm or they could have serious harm. We call these things serious events when the patient is harmed, and we pay a whole lot of attention to the events with serious harm. But all of these events have reached the patient. So to a certain extent, it's the nature of the event that impacts the patient. To a certain extent, it's the nature of the patient who's receiving that impact that determines how much harm there is. But wouldn't it be better if we could pull this back to a near miss where it doesn't even reach the patient? And we can get closer to that with simulation. And wouldn't it be even better if we could identify this hazard when it's still just a hazard or a latent safety threat? And that's something we can do in simulation. So there is a way to think about the threats to our patients. One is a situation, one is a regular threat. You know this one. This is like a cardiac arrest. It happens often enough that we have a standard response. We practice. What are we going to do if this happens? We don't know when it's going to happen, but we think it might happen. There's an irregular threat. That's something that is unexpected but not unimaginable. Ebola was one of these. That requires some self-organization and improvisation to manage. And then there are unexampled events which are completely unknowable ahead of time. And I think the 2009 tsunami might be considered an unexampled event. So with all these threats, we want to be resilient. So we want to be able to adapt to whatever comes so that we can do the best for our patients. And this is a whole Nagel definition of resilience: the intrinsic ability of a system to adjust its functioning prior to, during, or following changes and disturbances so that it can sustain required operations under both expected and unexpected conditions. The opposite of resilience would be brittleness, which is an inability to respond in that manner. And resilience is described as having four capacities. A system, you cannot make a system be resilient, but you can create conditions that allow resilience to emerge, and you can create conditions that interfere with resilience emerging. But the main conditions of resilience, the capacities, are the ability to learn, to respond, to monitor, and to anticipate. So maybe we have a patient care event, and we analyze it in this manner. We take the learnings from that, we create a simulated event, we try to learn from it in the same manner, and then we debrief after the simulated event, and we debrief about how individuals responded, how the team functioned, and also how the system supported or didn't support the actions. And then our hope is that those learnings, that anticipation, those abilities also are reflected when we have an actual patient event that may happen, and then it would become an iterative cycle. In debriefing, it's important to talk about what people did well as well as what they didn't do well. If we only, in debriefing, in safety, if we only continue to tell people what they did wrong, they're going to tune us out. And they're not going to learn the same things. So telling people what they did well is essential. And a bit about Safety 1 and Safety 2. So Safety 2 talks about telling people, reinforcing what people did well. Safety 1 is about things that go wrong, the things for which we do a root cause analysis, the horrible events. They're really only a small segment of the patient care we deliver. It is important to understand Safety 1 events. But the vast majority of the work we do actually would be considered Safety 2, things that succeed, things that help our patients, what goes right. And so we need to also reinforce things that go well. And it may have a greater impact to amplify a small thing that happens over and over and over and over again, rather than to try to constrain a one-off kind of unusual bad thing that had unusual contributing circumstances. So it's really a paradigm shift in debriefing and also in clinical thought. How do we actually look for and reinforce the things that went well? And how do we prioritize this when we have a million other things, objects that demand our attention and our time? And how do we be careful not to become complacent? Because sometimes things go well because people compensated in some manner, and we have to understand what that compensation is. We have to look at the margin people had in their actions and not consider it waste. But, the waste and margin are kind of two sides of the same coin. We know humans have significant limitations, but they also have tremendous capabilities. They solve problems, they have situational awareness, they understand, they can focus in chaotic environments, they make goals, we can anticipate. All these things are essential qualities. So I showed you before this example of simulation to improve systems. We used simulation before opening a new NICU and found that the room numbering was uninterpretable by the clinicians, changed the room numbering. Just when we brought pediatric patients into an adult facility, what do we need to look for? So simulation, from a safety to and resilience engineering lens, it enables frontline healthcare workers to better understand safe operating conditions and the margin they're working with. It allows them to enhance communication and teamwork behaviors. It reinforces good behaviors, increases adaptive capacity, and proactively identifies hazards. So humans are awesome. We are creative. We invent. We offer empathy and compassion. And it's those efforts that continue to improve healthcare. And with that, I'm going to let Vinay talk.
Thanks. Well, thank you. And I think Ellen has really set the stage. These, although I have some research grants and sit on scientific advisory boards, none of the photos that I'm going to show during the presentation are intended to endorse any product or medication, etc., just simply as examples. But I think Ellen has set the stage about the complex adaptive systems that we live and work in. And also, Kevin was mentioning how we kind of have embraced simulation as a skill training, behavior training, crew resource management training kind of system, but it's oftentimes put into a bucket of education and trying to get it out of the boardroom to the bedside, out of that bucket, and actually functioning to affect patient care and really relate to what we need it to do, to be able to pull from it so it affects our daily practice, is a huge challenge everywhere in the world. McGill, of course, is over the top, and today, as you probably know, right simultaneous with this presentation, there's a citywide mass trauma, mass casualty simulation doing exactly what Ellen was talking about, probing that system, seeing how the system works, finding the latent errors, and also those things that work really well, and then debriefing on it for one of those rare events that may or may not ever happen, hopefully never. But the preparedness and all of the sort of the subtext, the things that are discovered during that will probably improve the care of patients in this hospital, other hospitals, and in the community simply by having gone through that process. In resuscitation, we like to think about the medical science, what we know actually works. But that alone, in the past, when translated into courses and training, was expected to actually change the way we practice. And we know that oftentimes it takes up to 17 years for something that's discovered in the New England Journal today to actually make it into our practice to make a difference. And so we're now acknowledging much more that the educational efficiency and the local implementation have equal weights in that formula for survival and improvement. So for the next 15 minutes or so, I just want you to think with me about how we could transition from using simulation as an education mode to what we really care about, which is patient outcomes. And so Merlin the magician, who's this mythical magician who lived his life backwards, knew where he was and he knew what had happened, but he didn't know how he got there. And he just got younger and younger and started to discover what had happened in order to get him there. And simulation probes in some way can work that way to discover all the different channels and pathways that we can get to an end in mind. So when we think about simulation and simulation education, we don't often have proof or link it to patient outcomes. We often think about it as skill training, the FLS course, how do we get better, which is tremendous at skill training. But then how do we train the teams and the environment to actually do what we want it to do and to facilitate, as Ellen was saying, to allow us to be resilient and to respond to those expected and unexpected things that will come up during our daily practice or during those catastrophic events. In fact, when we use simulation education in order to affect patient outcomes, some of the really important aspects of that we've seen, and which I'm going to show you a few examples of, allow us to screen for the high-risk problems, to understand now using the electronic medical record, big data, and AI, we can sometimes predefine those patients who are at highest risk for expected or unexpected consequences. And that allows us to identify the providers and the patients that are going to encounter this problem, which we can then pre-brief and pre-train for. So we can use brief episodes, low dose but high frequency training to sort of just in time train and help ourselves to do better. We can also take those teams and use immediate or just after event performance feedback that allows us to improve while we're doing, and as in the military, using performance debriefing that uses both quantitative data from the event, like an RCA, but also qualitative input from the providers who were involved in that event to inform and improve, as Ellen was talking about, the next event that might happen. When we think about simulation and the amazing resources at McGill that we have, there are really two buckets that type of training falls into. It's using or studying simulation as a methodology itself. Is it better to use simulation or some other form of training to get to that end? But very importantly, it can be used to probe and used in situ in order to really inform work as done, not work as imagined, documented, etc. But what would I do? Where would I take that patient on the stretcher? Not what I do on a mandatory at the end of the year and I click that I know how to race, but I actually know how to race because I can show you that I can take that patient, I can transfer them, I can quell the fire, I can find the fire extinguisher, and I can actually move them out the door and know where the next safe haven is to move them. And until I and my team have to do that, it's oftentimes a cognitive exercise that I theoretically know how to do it, but the practical issue is often very difficult to accomplish. We know in simulation education that Kirkpatrick has delineated sort of levels of efficacy of that training. Do they like it? Do they learn it? Do they use it? And does it actually perform results in simulation on simulated cases? But what Kevin is challenging us to do is to say, let's not stop there. Let's translate this into the real world and have a mirror image of that. In that real world, did they like it? Did they learn it? Did they use it? Was process of care followed? And did it affect patient outcomes? And how we can integrate all of the forces in our hospital, they're measuring CAUTIs, CAPIs, all of the different infectious risks that we really are focusing on for certification and acknowledgement in the country. We need to start to focus on how we can mobilize those systems and integrate them so that we can actually move the needle for real patient care and measure the patient outcomes and figure out if these types of training interventions, simulation, are actually making a difference. When we think of that hierarchy, it's pretty easy on the bottom of the pyramid to show that simulation makes a difference. But it's very difficult at the upper echelons for patient outcome and population outcomes to really know whether simulation or simulation-based techniques are permeating. And one of the things that Ellen was suggesting is that if we learn in simulation how to observe, reflect, and debrief, by applying that to real cases and real patients, we may not need to use as much simulators, technology. We may be able to embed the principles of simulation-based learning into our general practice. And every hospital that we get to travel around to quite a few different environments, and McGill is really no different, I think, Kevin, than my hospital and many hospitals that are struggling with the same thing, that how do we take busy time away from busy practitioners and ask them to go to a sim lab that might be, a mile away or outside to do things that we could probably do in our everyday patient care. And wouldn't we benefit from linking those two? I just want to call your attention to a few publications that I think kind of summarize some of the findings. So this by Vicki LeBlanc in Toronto and her team there did a review of how systems and human factors have been applied and suggest that individuals, teams, environments, technological system, and patient factors are all key components that can be impacted by this type of training. What we do know in this summary by Dr. Cook in JAMA 2011 is that technology-enhanced simulation rarely reports patient and healthcare outcomes as the outcome of a simulation-based intervention. And so there's a lot of opportunity to not only do this, but also to study its effects and its impact. And most often simulation-based interventions were compared to no intervention at all, which isn't really fair. If you're taking time and effort to learn something, it's more or less, is simulation-based the appropriate way to go or not? In children, I'm a pediatrician, pediatric intensivist, and Adam Cheng from Calgary did the same for pediatric studies on outcomes from simulation-based research. And of 57 studies, of which about a third were randomized controlled trials, only 10% reported a patient outcome effect. So, Kevin, I think it's not surprising that this hasn't really been embedded in our hospital system because it really hasn't been studied adequately, and there's great opportunity to move that forward. But what we do know from, again, Dr. Cook and medical teacher in 2012 tried to tease out those key and rank those key elements of simulation-based interventions that actually make a difference and have been demonstrated. And at the top of the list are feedback and repetitive practice, just in time, at the time that you're receptive to hearing about it, not in a course 3 months ago, but right before you take care of that case in the OR that has that special flavor to it, that's something you might encounter that you weren't expecting or that you haven't practiced regularly. And then the last paper I want to call your attention to is this powerful paper by Mary Patterson and her group in the British Medical Journal of Quality and Safety, which demonstrated the value and the return on investment of in situ simulation and to identify latent safety threats and to sort of focus care and improve care on high-risk emergency events. Now, most of us, when we think about elite training, when we think about simulation and practice, we think about teams that work together. So, Kevin, you work with a group that's pretty tight in cardiovascular surgery, where the anesthesiologists, the techs, the nurses, etc., know each other, and they're quite a tight team, and they can do this kind of pit stop, efficiency. But many of us, like those that work at my hospital, I work at a 540-bed children's hospital in a 65-bed ICU with 24-bed step-down and 26-bed pediatric cardiac ICU. 200 of our 540 pediatric beds are intensive care beds, and we're staffed by a lot of different standard and rotating faculty and fellows and practitioners. So when you actually calculate the number of 5-person rapid response or code blue teams that configure to respond to any one child in our institution at any given time of day, there are more than a million combinations of ad hoc teams that have to come together and function well. So the challenges for us in that environment with ad hoc teams is very different from Kevin's challenge in the operating room with a very consolidated and consistent group of providers. And so we have to titrate the training, and we can't have a one-size-fits-all sort of program. We have to figure out how to contextualize the training just in time to those different types of environments if we're going to make a difference. But I like this picture in my mind of the importance of using simulation in particular, because to me it shows that reflection and thought, which we rarely have time to do in the clinical environment, is probably the most important component. It's not the fancy mechanical simulator there that does it. It might attract people into the room, but the important work of the simulation event is really that reflection, debriefing, and the figuring out of the why we did what we did. The work as done, but then why and how we're going to change based on that experience. And it also, to some degree, tells me that there's this reflective pattern where what we do in training needs to reflect what we do in care, and vice versa, that what we do in care needs to reflect what we train on. Because so often we're distracted by certification, by training requirements, etc., and we get distracted to do what checks the box on the checklist and not what needs to be done to do a better job taking care of patients. How can we move that needle back and forth? So in the next 5 minutes or so, I just want to give you a few examples of successes and failures of where we think there's some opportunity to kind of stimulate your mind to think about things that could be done in your environment that might move that needle forward. So this is one example that was done by a fellow in surgery, a simulation fellow, who was from Japan and was quite bright. And during his fellowship, we had just developed a special delivery unit where children who had very significant congenital heart disease we were doing exit procedures and in utero neurosurgical interventions for spina bifida. And really, it was kind of pioneering territory because there really weren't very many people around doing these particular surgeries. And it really required the involvement of an advanced cardiac echocardiographer, an interventional radiologist, OBGYN, anesthesia, adult practitioners who were working in a pediatric environment. And so we had these hybrid suites, but we didn't have much experience with either the patient type or the providers working together. And so in this case, before the event, we were able to assemble them, and with a very simple simulator, an inert mannequin, we were able to simulate, and you can see them sort of the day before the procedure, these folks working in their in situ environment, looking at the ultrasound of a child with a very abnormal heart. But in fact, that heart is an olive that's embedded in a bunch of jelly. And if you just look at the intensity on their faces and what they're doing, I mean, you would never know that this is an olive in a bowl of jelly. That's kind of stimulating that kind of discussion of who's going to stand where, what are we going to do, what will happen if, and how will we respond if something unexpected happens. And I thought it was just a really good example of how a very simple little tool in the right environment with reality created around it can actually feel real and move the needle. This is another unusual case. This is the case of an anticipated birth of Siamese twins. And that doesn't happen very often for us, even at the Children's Hospital, which is a referral center. And because it hadn't happened recently, it was felt to be very important to simulate with the various teams, the OB team, the 2 surgical teams, the 2 neonatal resuscitation teams, etc., this unusual event. And these children were anticipated to be joined at the chest and to be quite sick and maybe have transfusion problems, etc. So on the left-hand side, they had, through the ultrasound, they had created 2 mannequins that they had sewn together to look like the real babies, which are on the right side of your screen. And so they were conjoined, and they were anticipating these children were going to be very sick, and they were going to need to each be intubated and each have IVs, etc. And they were quite concerned that they weren't going to be able to keep it straight, like who was getting what in what IV, etc. And so what they did was that they rehearsed. They first took the individual teams, and they did a walkthrough. These are the simulated babies, and now they're talking and walking through what they think they would do, work as imagined, and now work as they are rehearsing and trying to do. And then they're debriefing after with the individuals in the nursing and the respiratory therapy and the surgical and the anesthesia teams as individuals. But then, as now is a more real-time, real-speed rehearsal, here comes the babies, and these are the simulated babies coming to the bedside, and now they're actually, as their teams, rehearsing what they're going to be doing during the event. And so, during this process, they then debrief, discuss what they're going to change, etc. But now, here's the real baby. Nope. That's actually the debriefing, sorry. So now they're talking and discussing it. And then, here's the real thing from a slightly different angle. Here the babies, they actually are crying, connected, and the team seems to be functioning fairly calmly, fairly connectedly, but they in fact did end up needing to intubate, labeling the different things in green and blue, and it worked pretty much according to plan. But they were prepared for many, many different alternatives as a more resilient team and environment than they had going into it 2 days before. So how do we embed this type of approach into our general care? It's not easy, but the concept that we use in medicine, we don't give a single dose of antibiotics or a single vaccination and expect it to work forever. We give low-dose, high-frequency interventions to bring things up to the level that we want to sustain. We might give a bolus dose to bring it up quickly, but then we have to give these intermittent doses. And that concept seems to work quite well in training and in resuscitation. So we went back through our resuscitation program in our ICU. We used the data on the outcomes of the children and the interventions, and we discovered that we weren't doing a great job with chest compression fraction, chest compression depth, and many of the post-resuscitation care. So we developed a program where each step of that was examined, reported, and then quality improved. And we used just-in-time training to identify, through high-risk monitoring, which were the at-risk patients, and we focused on those providers who were taking care of that with 2-minute refreshers for the providers around the sick child who was likely to arrest. And then through pre-briefing in the post-resuscitative care, we improved compliance with our targeted temperature management, blood pressure control, ventilation, oxygenation, etc., to bring it to a level that when we actually measured the outcome and debriefed, so it was the combination of the training and the debriefing of the real events, we actually doubled the survival and intact neurologic outcome from 29 to 54%. And so what we know, how we use our guidelines, clinical pathways, medical standards, what we teach, learn, and remember, and then what we do are all links in the chain of survival that are sometimes lost in translation. And by using a process of rigorous evidence evaluation, deliberate practice, and quality improvement, we can really move the needle and change that so we lose less in translation. The American Heart Association has now adopted that process and has moved from ACLS and PALS training, along with the heart and stroke, from every 2-year certification to a rolling refresher cart that has your mannequins on it that comes to you at the bedside, and that every 3 months you can update a skill and go online to do a virtual practice, and that forwards your certification with the American Heart Association for your ACLS card. And so that, moving forward, could also be translated to your learning management system to fulfill your credentialing at your local hospital, and could also be transmitted to your board to be able to give you your maintenance of certification updates. And so this linkage of that is good, but that's still training. And we're working with the American Heart Association now to be able to record your performance during real resuscitations, so that if you can upload your performance there and be debriefed locally, you can get credit for a real resuscitation towards your ACLS recertification. Moving what we do in simulation and training into the real world and then back again to credential you and give you an incentive in order to do it. We've done this now, and we are in 40 children's hospitals collecting real data on resuscitations from the monitor defibrillator output, uploading it to a separate center, and tracking pre-briefs and debriefs, and giving people credit back and dashboards so that they can compare their performance to the 40 other hospitals reporting in a confidential manner, de-identified to the world, but identified to them so they can improve their performance, moving it forward. The Get With the Guidelines Resuscitation Registry in 340 hospitals in the United States is gathering clinical data, but no simulation data, no training data, and now is developing a system for you to be able to upload your mock code information and your training information and your CSV files from real resuscitations from the bedside, so that now you will be able to match your real performance with a Get With the Guidelines registry with a simulation and training-based registry, so that you can start to interface and figure out, how do I need to change my training in order to change my practice and my patient outcomes? So it's getting better. It's not there yet, but on the horizon, I want you to think about how those systems could work to benefit you. That's a system that has come from a clinical data collection, a registry of clinical events, that is now embedding and using simulation. Let me tell you about a simulation collaboration that's going the other direction. So this Inspire Network, the International Network for Simulation-Based Innovation, Research, and Education, is a loose, voluntary collaborative of almost 200 children's hospitals now that are using and collaborating to try to use simulation to move the field forward. This collaborative has subsets that have looked at infant lumbar punctures and how to decrease the number of unsuccessful lumbar punctures by having a very simple toolkit that they use to do just-in-time training for residents who are early in their training with supervision from their senior residents. And so they have this little tool and a checklist that they use that they run through right before they do the procedure, very similar to what you might do in the operating room if you're doing a procedure or a lap type of procedure and you have somebody who's not so experienced and you want them to run through a training session beforehand. And they are working to try to embed that into clinical practice because they discover that it actually does decrease the number of punctures that it takes to get clear fluid. Another subset is called the impact subgroups, improving pediatric acute care through simulation. And what you may know is that we focus on the simulation-based outcomes. What we want to improve is patient outcomes. And what you may or may not know is that pediatric readiness is different in adult or general emergency departments from pediatric emergency departments. And the volume of children that a given site sees from low, medium to high, if you go in and assess the pediatric readiness, which the emergency medical system for children did twice in 2006 and then again in 2012, they discovered that the volume of patients you see is related to your performance. And so this group recruited different pediatric hubs in different states across the United States. And then those hubs adopted and tested with simulation-based probes community, adult, and pediatric emergency departments in their region. And they created very standardized cases and with standardized confederates or actors and outcomes that could be measured with time-critical interventions and for both skills, behaviors, and leadership. And this encompassed more than 1 million catchment area, 9 pediatric centers and 61 adult or community centers. And the in situ simulation was then the environment for this research project. And with these very standardized simulations for foreign body airway obstruction, a seizure, simulated sepsis case, and a cardiac arrest case, they probed these places with very standardized tools, and they generated spiderograms that were able to identify the difference between low and high volume performance for the different cases, and then could generate a report for low and high volume, and in the blue is the actual site's performance, so they could then benchmark themselves on quality improvement, policies and procedures, patient safety, physician and nurse staffing, equipment and supplies, etc. So they could have these benchmarks to rate themselves, and then they could go back and reprobe. So along with generating the report card, it had specific checklists for what could be improved in the context of that particular site. So it wasn't just a generic checklist, but it was trying to look at what they could improve, what latent safety threat they identified, and the action items. The experts helped the local team decide what they wanted to work on as their action items. And then 6 months later, they would come back and reprobe to see if those action items had actually made an impact. It's not quite work as done because they're not real patients, but it is work as simulated. But then the next step that they're doing right now is measuring the outcomes of those same types of patients that actually present to those pediatric, community, and adult ERs, and they're measuring the actual process of care and outcomes based on the same checklist. So they're moving closer to that mirror image that is going to give us that data that will suggest whether this type of effort has a return on investment in terms of patient outcomes. This has been reported in JAMA Pediatrics and several other journals, but is not just restricted to resource-rich environments like Montreal and Philadelphia. In Botswana, Peter Mini and his team have taken this concept to Botswana, Tanzania, Ethiopia, and India, and using a very similar system with much simpler interventions, they've demonstrated that we can improve and sustain knowledge and skills, not surprising, but actual mortality by linking with the hospitals and measuring the performance, process of care, and outcomes of the patients. At Scottish Rite Hospital in Botswana, outside of Gaborone, they were able to demonstrate that the baseline mortality of children coming into the hospital was 2.8% to the wards. And by using just the simulation-based training in the initial period, they were able to decrease mortality by about 22%. But when they added quality improvement programs, debriefing and monitoring of real patients as well as their simulated outcomes, they were able to further reduce to an 80% reduction in death of children coming to that district hospital. And so some early evidence that perhaps this is not restricted to resource-rich environments, but very simple tools with the same concepts can make a difference. This has been played out in the other environments and in the Helping Babies Breathe program that is very prominent and has been published in JAMA now from Tanzania and Ethiopia. Simple tools. So let me sort of finish up then by just talking about where we're headed. We have programs where we're starting to use this not just in the hospital, but in the field. In India, road traffic accidents are a huge problem. There are more arguments that there's actually rescue going on, and the outcomes are really impressive. 1 child is killed every hour, 15 people are killed every hour, and 60 are seriously injured or disabled every hour in road traffic accidents in India. Our reports currently are about 30% of those are due to untreated bleeding at the scene. That simple pressure or tourniquet could probably sustain life. And so by using a network of the EMRI, the Emergency Medical System, which is already using simulation to train, their telephone dispatchers and the drivers of the little jeepneys and the roadside vendors, and training them on how to stop the bleed, call 108 there, and apply a tourniquet. And using a drone concept, simulation is trying to figure out how to get beyond the road traffic accidents, geolocate through their cell phone where they are, get what they need to the resuscitators at the field, and then track their outcomes through their hospital course to see if it can make a difference. As we move forward, there are challenges. How many people need to be trained? Does everybody need to be trained? Is it more like immunizations where there's herd immunity when enough people are trained that we can sustain resilience? Can we use those principles that are used in sports training, coaching, in order to improve the outcomes? Can we use signals like they use in football games? Can we create a fun learning environment like fantasy football? And can we learn to use instant replay like we do in our big sports events? High-stakes environments, millions of dollars being spent, and all of us in the stadium and at home can see instant replays and make our own decision about whether something was right or wrong, should have been done differently.